Okay, so welcome you guys. Today I'll be talking about some of the updates from the Oncology AMP 2017 conference that happened in Arizona a few weeks ago. I'll just go over a number of different presentations that happened there and highlight some of the research that was brought forward and how that can kind of lead into how we approach cancer patients in the context of integrative cancer care. So one of the really interesting topics here was cannabis use in cancer care, kind of a hot topic right now. So what kind of is the research out there and how can we best use this for our patients? This material was presented by Dr. Donald Abrams. He's a medical doctor. So I'll just briefly give you some of the information that he brought forward to us. Right now, there's discussion about what is the best CBD to THC ratio in terms of cancer care, and we don't actually have any information in the literature in terms of what's most effective for side effects of chemo and also for treating cancer, which is kind of like the new idea of how could cannabis use to actually directly treat cancer and not just symptoms. Obviously, this is very, very preliminary, just ideas at this point. There's some studies, this one is highlighted here, a randomized double-blind study that showed cannabinoids being helpful for appetite, especially in patients that are going through chemotherapy and are losing their appetite and are losing weight. So this here is the cannabinoid. It was a 2.5 milligram preparation taken twice a day. And then this is the more conventional management, which we learn about. This is oral progesterone, kind of a last-ditch effort to increase appetite in these patients. You can see that appetite increased in the cannabinoid group by 49%. Weight also increased by 10%. And then one study, one randomized controlled trial actually showed that food actually tastes better in the cannabinoid group. And so patients were more likely to eat more of it as well because they had this increased perception of taste. So cannabinoids, cannabis, and chemotherapy in terms of associated nausea and vomiting and pain that can come along with the chemotherapy regimes. So the presenter told us about how oral THC is actually better or equal to this medication here, prochlorperazine, which is an antipsychotic used to treat nausea and vomiting and also schizophrenia. And also he said that smoked THC was more effective than oral THC, so interesting there. How does this work? So the cannabinoid receptors, CB1 in particular, are found in areas of the brain that actually modulate the pain response. So the idea there is that we can affect those receptors and then have some kind of downstream effect in terms of symptom management. CB1 and CB2 receptors are also anti-inflammatory and are found in different tissues throughout the body as well. IV THC, there's been some studies on the potent analgesic effects of IV treatment. And when in one trial here, oral THC 20 milligrams was given, it was very comparable to 120 milligrams of codeine, which we know is an opiate, kind of on the far spectrum of the opiates, not a very, very strong opiate, but used for pain management. There is, of course, more psychological effects with the THC, so something to discuss with your patients. Hi, come on in.
What's going on?
So this is a presentation on the Oncology AMP updates.
Did you call me?
Yeah, I did, and we figured it out.
Oh, okay. I got your message, and I was like, what's going on? Everything looks good to me.
Yeah, it's all good. Thank you.
Nice job.
Thanks.
Yeah.
So also there's an aside here. He presented some research on HIV neuropathy and cannabinoid use, and that it's actually a potential alternative to opiates and potentially an alternative to anticonvulsants like gabapentin or pregabalin, which is not always very effective in HIV neuropathy. So keep your eyes out for this one too in terms of its future use. But of course, keep in mind the law and the state that you practice under, and be very cautious about prescribing medical marijuana and making sure to abide by the law and wherever you're practicing. Cannabinoids and opioids So there was some question, well, if we give cannabis to a patient, is that going to enhance the effect of their opiate use? Well, in mice, there was a study that THC does in fact enhance some of the analgesic effects of opiates, and morphine was studied in this one. This remains potential in human beings as well. There are some clinical trials on this that vaporized cannabis and opioids taken together is in fact safe. And there's one study on oxycodone and morphine that patients that were given the cannabis, they had increased or enhanced analgesic effects. So the big question here is cannabis and cancer. Is there a connection? If patients are smoking cannabis, is there an increased chance of lung cancer? Well, from the studies we have so far, no. The conclusion seems to be it's not correlated to cancer, other than this one study here, the testicular cancer. Systematic reviews and meta-analysis of 3 case-controlled studies did show that there was an increased risk of non-seminoma germ cell tumors in particular. So keep this in mind. I don't think the jury's out completely on this yet. Also, here's kind of where things are heading to, that cannabis may have some anti-tumor effect directly by the cannabinoid receptors that I said are found kind of throughout the body and in different tissues. How that's proposed is potentially apoptosis and then slowing tumor vascularization, which is how tumors get nutrients, right? Is by growing more vasculature. At this point, we only have in vitro studies. So this is a resource that we were pointed to. It's a good one for us as practitioners to kind of see what is the latest research out there, what in vitro studies are being done, what in vivo studies are being done, what human studies are out there. So that's for your reference. This was one of my favorite presentations because it was so simple, yet we see a lot of really profound results with the Mediterranean diet, as we know. This was presented by Dr. Michelle, and I don't know how to pronounce her last name. She was really great. So we've all studied this, that there's been a lot of connection between adherence to a Mediterranean diet and prevention of several neurodegenerative diseases, improvement in diabetes, type 2, cardiovascular disease, and now potentially cancer. So here's this large trial here where over 25,000 participants were included over about 8 years. There was an overall decreased risk of cancer in this group, just a preliminary kind of study. This is the result here for developing breast cancer. This is the first study that shows that there's any correlation between a dietary intervention and the risk or decrease or increased risk of developing breast cancer. So again, first randomized trial. So that's exciting. In this, there was 68% a reduced risk of developing breast cancer in the Mediterranean diet, was supplemented with some extra virgin olive oil every day. Here's another study. So 307 women with early stage breast cancer were treated with cancer-reducing dietary advice, just very, very general advice, and then 109 were counseled on a specific Mediterranean diet. And then 3 years later, there were 11 cases in the general kind of nutrition advice group, and then none in the Mediterranean diet group. So again, very preliminary, not randomized, not placebo-controlled, of course. But something to keep in mind for our patients. Colorectal cancer, 8 to 11% decreased risk of developing colorectal or colon cancer. And this was a very large study, over 5 million person years. And then another study showed a 17% reduction. So that's all good news there. Prostate cancer, we have 1 case controlled study where there was a 4% reduced risk, and also from 4 cohort studies. And then from liver cancer as well, we have a cohort and a case controlled study that showed a 42% reduced risk. So here's the Mediterranean diet. Over here, as we're all quite familiar with, diet high in fish and legumes and whole grains and fruits and vegetables and olive oil every day. Fairly low in meat and red meat and that sort of thing. Fairly low in poultry and fairly low in full-fat dairy. This was one of my favorite parts of the presentation because it really took a lot of abstract kind of research things that the presenters were bringing forward to, like, how do we actually apply this to our patients? How do we actually implement dietary changes with our patients? So this was really helpful, and things that can be applied to any of our patients when we're trying to make dietary changes. But a couple specifics here for the Mediterranean diet. So she was suggesting, adding foods rather than taking them away. Seems pretty intuitive, but kind of giving people more freedom with their diet, initially at least. Adding 1 to 2 foods at a time rather than shocking them, like, oh, you have to eat 5 to 7 fruits and vegetables now when they are used to eating none. Maybe adding just 1 for breakfast or 1 for lunch and kind of going stepwise. She suggests replacing fats with olive oil, extra virgin olive oil, except for high heat cooking, of course, as we know. And then replacing simple carbs with complex carbs, but doing it slowly. So if someone's really used to white rice, bringing in brown rice and doing a 50-50 mix, something like that. And she emphasizes carotenoid-rich vegetables to really cook it in a lot of fat to bring out those nutrients. So in, you're making your pasta sauces, adding a lot of extra virgin olive oil and cooking on really low heat for a long time, kind of thing, and letting things simmer. For people who are used to eating a lot of meat, she suggests adding just a little bit of meat kind of more as flavoring rather than making it the bulk of the dish. She emphasizes making tons of leftovers, also taking cooking classes, getting your patients really involved in their process of cooking and nourishing their body, as well as rather than eating many meals throughout the day, but really sitting down and having your meals in smaller courses, and people are more likely to eat less if they do that. And I hadn't thought of that as something to bring in for patients. So breast cancer treatment, specifically for treating menopause symptoms in breast cancer positive patients. This was presented by Dr. Tori Hudson. So issues that are facing these patients as they hit menopause are going to be vasomotor symptoms, urogenital symptoms, osteoporosis, potentially cardiovascular disease, insomnia, anxiety, depression, and also dry skin, maybe some acne, hirsutism, hair thinning. So these are going to be concerning symptoms for your menopausal patients. So how do we treat them differently if they have an active breast cancer or they've had a history of breast cancer and they're at increased risk of recurrence? So here are some nutrients that she suggests that she likes. So for hot flashes, she suggests soy isoflavones, fish oils, vitamin E. For depression, here's a list: anxiety, insomnia. We're familiar with a lot of these. So I want to go kind of more into specifics around breast cancer diagnoses. Soy isoflavones, there's really not a lot of clinical evidence that taking these in by your food is going to increase your breast cancer risk for healthy women. Those with a history of breast cancer, again, there's Tori Hudson said there's not a lot of evidence to show that there's an increase in breast cancer with those patients as well. There's a large study here, the Shanghai Breast Cancer Survival Study, actually showed lower progression rates with higher levels of soy intake. The suggestion here is between 60 and 100 milligrams per day and to not exceed 150. So you can kind of like work through that with your patients, trying to get that level from food. If you think they're eating too much soy, you can maybe put it in some kind of calculator and see how many milligrams they're having a day and make recommendations around that. But she generally suggests 1 serving of a soy product per day for these patients. So she actually suggests that patients start eating this really early, that women should be eating this even as they're going through puberty, kind of way before potential breast cancer would be on the horizon. So that's what she emphasizes. She does suggest to avoid these herbs, red clover, hops, and kudzu, just because they do have a higher concentration. I don't think there's many clinical studies around that, but she just says be cautious. What about omega-3s? So this is interesting for dry eyes. There's a intervention here where there was 70% symptom improvement with 450 milligrams of EPA and 300 milligrams of DHA with 1,000 milligrams of flaxseed per day, and only 7% improvement in placebo group. So keep this in mind for your patients who have dry eyes. There's also an association between omega-6s and breast cancer risk in premenopausal women. We don't know. I mean, maybe this is correlation versus causation. Keep that in mind. These are just preliminary studies. And higher intake of omega-3s in obese women led to decreased risk of breast cancer. Again, is this correlation versus causation? Are people who are more likely to eat omega-3s, are they more likely to exercise and do other healthy things? We're not really sure. Also keep this in mind for an intervention for chemotherapy-related weight loss. There was a study here at 2.2 grams per day. 69% of patients kept their weight. So that's not a huge dose. That's 1 teaspoon of your fish oils. You're going to be able to get that. And this is just one study, but something to keep in mind. For vasomotor symptoms or hot flashes, unfortunately, this intervention wasn't very effective. At least at 1.8 grams a day after 12 weeks didn't show any improvement. So Dr. Tori Hudson loves a lot of different botanical medicines for hot flashes. Her favorite being black cohosh. She said there's over 125 papers published right now on its safety profile. And there's some other ones to think about. And as you look at the patient in front of you and kind of see what else you want to support in their life. So black cohosh and breast cancer safety. So it's not a phytoestrogen. It seems to be very safe in breast cancer patients. At least in vitro studies, there has been no breast cell cancer growth. It's also safe for women on tamoxifen or raloxifene. So the proposed mechanism of action, we don't really know how it works, but Dr. Hudson thinks it might work similarly to an SSRI. The bottom line is that in general it is safe for patients, and my next slide I'll show you some cautions around it. This is the dosage here, if you want to put that in your clinic notebook, and it can also be used for dysthymia and rheumatism, so keep that in mind. Some in vitro studies did show that it increased the cytotoxicity of doxorubicin and docetaxel, so keep that in mind. Also cisplatin potentially decreasing the cytotoxicity, so that could be a concern, but no effect on radiation. So do this, use it case-by-case example, but Dr. Hudson uses it a lot for her breast cancer patients and feels very comfortable with it. Just a couple more additional clinical pearls that I took away from her presentation. This is something that's kind of new. 5% fennel cream for vaginal atrophy. There's just been one study, so keep that in mind for your patients. It's helpful for pruritus and dryness and balancing the pH. And what about low-dose vaginal estrogens? This is something we like to put our postmenopausal patients on for vaginal atrophy. It carries very low risk for breast cancer patients. As always, if you see symptoms or your patient reports symptoms of spotting or bleeding and they're postmenopausal, do diligence and always go on with the transvaginal ultrasound or endometrial biopsy and make sure that there isn't something else going on. There isn't some kind of hyperplasia or uterine growth. And ACOG has put out their statement for vaginal estrogens that there's no increased cancer risk amongst women who are undergoing treatment for breast cancer or with a history of breast cancer. So back to vasomotor symptoms or hot flashes and botanicals. So again, first line, think about black cohosh and a serving a day of some kind of soy product. Second line, these are what Dr. Hudson likes, and then avoid these, as I said before, to their potential estrogen stimulating effects. This is an interesting presentation on. So this was done by Dr. Beer, who's an ND, PhD, LIC, and has FABNO as well. Kind of controversial in terms of the effectiveness of breast cancer screening, and should we be rethinking this paradigm of how we screen patients for breast cancer? As we know, the USPSTF has their recommendations of screening every other year starting at age 50 to age 74. In terms of its effectiveness, in terms of overall mortality, this is by implementing some kind of screening. This is what he was talking about. So he brought up some interesting information. So for every 2,000 women that are screened over 10 years, you'll only kind of save one patient from dying directly from breast cancer. So it seems low for a vast number of women that we're screening. But of course, you don't want to be that one. You don't want your mother to be that one. You don't want your sister to be that one. And out of these 2,000, 10 healthy women will be overdiagnosed and they'll be treated unnecessarily. In other words, they wouldn't have had a diagnosis if there wasn't a screening, because it would have, the natural course of their growth would have just been to recede back to normal. And also, according to this one study that was brought forward, 200 out of the 2,000 patients will have some kind of anxiety or stress, of course, related to the experience. And also uncertainty around false positives. If a woman is told that on mammography something came up, but then there's kind of an extended time between when it's biopsied, there is obviously going to be a lot of stress and concern during that time, which makes sense. So this is an interesting little visual put up by the Swiss Medical Board. So this is kind of our perception of how effective mammography is, and this is how effective mammography actually is. So let's look at this together. So with screening, we have this large chunk of women, 331 women. Our assumption is that about 10 women will die from breast cancer, and about 39 will, that's 30. 30 women will die from breast cancer, 39 women will die from other causes. And then we think, okay, well, if we didn't screen them, 160 women would die from breast cancer, and 39 women would die from other causes. This is kind of what their study came up with. But if we move over here to the real effect of mammography, 4 women will die from breast cancer with screening, and without screening, 5 women will die from breast cancer. So in effect, only 1 woman is kind of being saved by this screening guideline in this example out of the over 900. So the discussion question is, what would you tell patients about breast cancer screening recommendations in terms of how effective it is? Because it's something that we just accept, especially as primary care providers. You recommend your mammographies. Self-breast exam is no longer recommended according to the USPSTF, but mammography is standard of care. So he's just kind of questioning this paradigm. So maybe I'll throw it out to you guys. If a patient comes in and asks about the effectiveness of screening mammography, kind of what dialogue would you use with them? Say someone's like, I have no breast cancer history, I have no family history, very healthy. I don't want to start doing mammograms because I don't think it's effective. What would you say?
I think from what you said, there's a little bit of effectiveness, but there's also the possibility of increasing anxiety and worry. So having a conversation about that, if there's somebody who has a tendency to get worried about things, that would be enough to convince me that maybe it's not beneficial.
Okay.
Yeah, I agree on the informed consent, and hopefully you're developing this relationship with your patients, and figuring out what's important, what their values are, kind of acting accordingly.
Yeah, good points, for sure. I think the informed consent is key. Of course, as we're primary care providers, if we choose to stay in Washington and act as PCVs, it is our due diligence to present this as standard of care to our patients. But in reality, we get a lot of patients who do not want to follow standard of care. So kind of having, I think that's one of our benefits as naturopathic doctors, is having more time with our patients to say like, okay, here's the data. It's up to you. I would still recommend getting the mammography, and here's kind of the outcome, and let's walk you through that and see where your comfort level is as a patient. So kind of general points for discussion for breast cancer or just cancer screening in general. What do you think should be the benchmark for determining the efficacy of a screening recommendation? Do you think that should it be overall quality of life? Should it be overall mortality? What should that benchmark be? So this presenter was basically bringing up the point that a lot of our screening recommendations are not decreasing overall mortality in the way that we would want them to, in the extent that we would want them to. So he, again, is kind of challenging that. Obviously, not all screening recommendations are created equal. Some are very good, like preventing colorectal cancer, colonoscopy starting at age 50. We have good evidence around that. But in terms of prostate cancer screening, that's changed based on data. So what do you guys think should be a benchmark for determining if a screening recommendation should be implemented on a wide scale?
I mean, mortality is kind of the easiest one to measure, but it doesn't take into account like quality of life issues, which are harder to measure. Mm-hmm. So it does seem to be a hard one to measure. But in this case, where mortality benefit is so small, it's something we should at least think about. What's the effect of quality of life, and how can we measure it?
Great point. Yeah.
Yeah, and also, I mean, it feels like the algorithm needs to be a little bit more complex in the sense that, the recommendations of, is this person likely to die of their disease if they're of advanced age, for example, or also, are we able to treat it? Is the treatment acceptable? I guess the quality of life question, but for example, are there things specifically naturopathically that we can do if something comes up on screening that naturopathically we know we can reverse or kind of be able to help it not progress to a later stage disease?
Great points. You saying that kind of reminded me of Dr. Yanel did a presentation on prostate cancer, which was similar to what we kind of got in class last year. But having a low Gleason score, like a 3+3 or a 3+4, is kind of like that watch and wait model. And as NDs, we have a lot to offer during that time, and to do good screenings, regularly, to make sure that it's not progressing really fast, to make sure that it's staying kind of this slow course. But we have the tools to actually make a difference at that level, which is really cool. So it's a good point. I think prostate cancer is an awesome example of that. If overall mortality was changed only by a little bit, would you still recommend screening for something, say, like breast cancer? This is a tough question.
It's tough because if you see a lot of people and you're kind of telling them not to get screened, after 2,000 people, you potentially maybe killed somebody. So it does add up over time.
Yeah.
So like, for example, breast cancer, you're saying specifically?
Yeah.
Like, it's interesting also naturopathically, we talked about this in class, ACOG has different recommendations than your
Right.
And that's because it's by clinicians, right? We see this. So that question of, even though the self-breast exam and even clinical breast exam isn't as indicated, like, do we still want our very well-educated patients to know their breast tissue and be able to observe changes in their breast tissue as part of their own screening too?
Yeah. Great point. I think this is hard because, again, we have this standard to uphold that has been it's a grade B evidence for the USPSTF. It's not grade A. But at the same time, we wouldn't want that one person to be our mom. We wouldn't want that one person to be our friend or our sister. And so having, again, that really good informed discussion of like, this is what we recommend. but here's the realities, here are the facts, this is what research is coming out with. Now it's up to you, patient, to decide what you want to do. So I think questioning these kinds of things is good. I think still, my personal belief at least, upholding those standards that have been kind of set out by things like the USPSTF and you know, societies like ACOG, et cetera. I think we have responsibility as physicians to always uphold that and at least explain that to our patient. And then what our patient decides past that is of course up to them. So here's another question. Would you treat a cancer if the natural course of many cases, but not all, is to spontaneously regress? Again, this presenter was saying that a lot of kind of breast tissue proliferations, breast lumps, will often be overdiagnosed, overtreated, and a lot of them will kind of become normal tissue after some time. But then of course there's patients that you're not going to have that, and they're going to turn into an invasive cancer. So what do you guys think?
I guess I would want to know some numbers on likelihood, and once again, it's an informed discussion.
Yeah.
And if it's a reason to get the person to adopt better lifestyle habits, then it could be a reason maybe not treat.
Yeah.
But if it's someone who's not, then maybe it's more of an argument to actually go with more aggressive treatment.
I guess in the state, we would, if they're already at the point where they've have a diagnosed cancer, that we need an oncologist on board anyway. So having really good communication and being able to like track with scans and really keep it. Also, the patient, if they're likely to adhere to such regimen as well, and
Yeah.
have the oncologist on board too.
Yeah, definitely. Of course, yeah, in Washington we have to have oncologists on board once for the diagnosis and treatment. The reason I asked this question is because DCIS, I think, is a great example of this, of what is this? So ductal carcinoma in situ. There's a movement towards pulling out the carcinoma, the C part of this diagnosis, because it scares people into thinking it's a carcinoma. But we know from our pathology class that in situ means it's not broken through the basement membrane yet, and it hasn't become invasive to other tissues. But there is a chance that DCIS can become invasive, and so we really want to prevent that, of course. So here's some questions, or some facts. So removal of 50,000 to 60,000 DCIS lesions per year has had no reduction of incidence in breast cancer, according to this one study. All right, so keep that in mind. So conventional MET treatment, as we know from oncology class, is lumpectomy and radiation, or mastectomy for DCIS. This is generally followed by 5 years of some kind of adjuvant treatment like tamoxifen or an aromatase inhibitor. And according to this one study that he brought forward, is that radiation lumpectomy results in 60% reduction in breast cancer, but overall no benefit for survival. So again, what are we measuring? So you're preventing the breast cancer in 60% of cases, which sounds awesome, but in the end of the day, there's no benefit for survival. And he also brought up that there's a slight increase in mortality when the radiation therapy is done, especially over the left side. So taking into that account, what would you guys recommend to your patients about DCIS? And would you recommend treatment or not? Say you've got a 50-year-old female patient, has come into you for a second opinion, has been diagnosed with DCIS, and their oncologist is recommending standard conventional treatment. Say they have no personal breast cancer history, no family breast cancer history, and no risk factors. What would you guys do in that situation?
I definitely would like a second opinion from a breast cancer oncologist. But yeah, seeing these statistics basically saying there's not a huge benefit from going there and surgically intervening. So I think these are good things to talk about the patient with. But I guess I would hesitate to really step too much on the toes of the oncologist, because I imagine their opinions can be different on this.
Good point, yeah.
Yeah, I mean, I'm just interested because tamoxifen has such strong side effects, including like future endometrial cancer and all this, that it'd be really interesting to look deeper into these studies and see
Yeah.
that cost
Yeah.
benefit.
I think it's really hard too when patients come up, to us and say, well, what would you do if this was your body, if this was your mom, if this was your sister, what would you recommend? And I think that's a really hard question to answer, not something that I've had experience as a student having to answer yet, but I've seen practitioners having to answer that. And again, it's our job to, especially in the state of Washington, being primary care providers, it's our job to present what conventional management is and to also align with our MD counterparts, and to create a team. We might have slightly differing opinions, but in the end of the day, to not cast judgment on those opinions and not to cast judgment on eventually our patients' decisions, but really just give the best, hopefully most non-judgmental and hopefully as non-biased as possible kind of presentation of the facts to our patients. And that's kind of where my philosophy as a student lies, at least. But it's difficult. These questions are obviously really difficult, and I think they take a lot of time to work through with our patients. And at least what I see as a student, like, we often have those opportunities to spend the time educating our patients. So that's super powerful and exciting for us as future doctors. Any questions? That is the end of the presentation.
Would you go to this conference again?
Yes, I would. It was really fun. They fed you really well. The presentations were really interesting. This is only about a third of all the presentations. It was very intensive, a lot of information, a lot of research, kind of preliminary ideas, ideologies, kind of theories were thrown out. So in terms of actually applying this to our patients, I really tried to pull out, like, from all the presentations, like, what can I bring back to you guys in terms of how can this affect our patients in a clinical setting. So I would have liked to see a little bit more of that, but the research for sure was incredibly interesting. And if you guys want any more information on that, I can tell you as well. Yeah.
Kind of briefly, did they go into any with the DCIS, like if there was, just like how much it is, any restriction of people who choose not to have a lumpectomy or choose not to be treated, and following them at all?
That's a really good question. It wasn't brought forward. If there is a study out there, it wasn't talked about. But definitely something to look at, because that would be kind of my next question. It's like, what would happen if we left this and didn't go through the treatment? Of course, that's risky, because then we're going to have to take a group of people who are willing to go to say goodbye to the conventional treatment, and that, of course, carries potentially some ethical considerations as well. So I'm not sure if that's out there, but definitely worth looking at. Yeah. Thanks, guys.
Nice job.
Do I just